Hello, and welcome to the accompanying lecture for Chapter 407, Antiplatelet and Anticoagulation Therapy for Interventional and Microvascular Procedures in Patients. Endovascular angiography is the principal diagnostic tool for many cerebrovascular pathologies of the central nervous system. Cerebral angiography carries a known risk of thromboembolism that can be minimized with careful technique. However, it is important to advise patients that despite the best technique, there is a basal rate of stroke with permanent disability around 0.14%. To reduce the risk of perioperative strokes, systemic heparin can be given. Monitoring of the ACT, or activated clotting time, is an important part in monitoring the response to heparin. We recommend during a transfemoral diagnostic angiogram giving a bolus of unfractionated heparin at a dose of 50 to 100 IU per kilograms with an ACT goal of 150 to 300 seconds. If an intervention is planned, another bolus of 20 to 40 IU per kilogram per hour should be given. Alternatively, pressurized heparinized saline through the femoral sheath can be given, and heparinized saline flushes used. For transradial angiograms, as was done in the Spirit of Artemis trial, we recommend a higher dose of heparin, 100 IU per kilograms, in order to reduce the rate of radial artery occlusion in comparison to lower doses. It is important to know that heparin has a short half-life and a pharmacodynamic effect of only 1 hour. During endovascular intervention, we recommend monitoring the ACT every 20 to 30 minutes with a goal of an ACT between 250 and 300 seconds. If the ACT is below goal, additional heparin boluses should be given. Patients with a history of heparin-induced thrombocytopenia, or HIT, require special care. For these patients, we recommend an initial bolus of 0.75 milligrams per kilogram of bivalirudin, followed by 1.75 milligrams per kilogram per hour, given every 4 hours. ACT and APPT should be monitored with a goal of 1.5 to 2.5 fold increases from baseline. After bivalirudin is given, a therapeutic ACT is usually achieved within 5 minutes. For patients on preoperative oral anticoagulation, it is recommended the anticoagulation be stopped 5 days prior to the planned procedure. Patients at high risk for thrombotic events should be transitioned to a heparin intravenous infusion to allow for rapid reversal if needed post-procedure. The stoppage of antiplatelet medications is highly dependent on the specific patient and reason for antiplatelet medications. Now we move on to antiplatelet and anticoagulation use for specific endovascular procedures. For the traditional coiling of aneurysms, the use of systemic heparinization is recommended intraoperatively. The addition of antiplatelet therapy is not the standard of care, but may be considered in select patients to lower thrombosis rates, although further prospective data is recommended to elucidate the use of this. Now we move on to antiplatelet and anticoagulation use for specific endovascular procedures. For the traditional coiling of aneurysms, the use of systemic heparinization is recommended intraoperatively. The addition of antiplatelet therapy is not the standard of care, but may be considered in select patients to lower thrombosis rates, although further prospective data is recommended to elucidate the use of this. The Webb device, a relatively novel device for aneurysm embolization, is used for the treatment of both ruptured and unruptured wide neck saccular aneurysms. The trial WEBcast 2 utilized a pre-treatment regimen of aspirin 100 milligrams per day for 3 to 5 days prior to the Webb deployment with no post-procedural antiplatelet therapy. That trial reported 14.5% of patients had thromboembolic events. For complex, unruptured, wide neck aneurysms, we recommend dual antiplatelet therapy of aspirin 81 milligrams per day and clopidogrel 75 milligrams per day for 4 days prior to the procedure in the event that stent placement is needed. Additionally, If the web device has any protruding segments into the parent vessel or evidence of thrombosis in the parent vessel intraoperatively, continuing antiplatelet therapy for up to 90 days is recommended with serial angiographic imaging post-procedure. The pulse-writer device is somewhat similar in idea to traditional stents, but this device minimizes interluminal metal while still allowing for complex Y or T configuration treatments. We recommend initiating a dual antiplatelet therapy consisting of 325 milligrams of aspirin daily and 75 milligrams per day of clopidogrel with a duration of 6 months post-procedure. Important to know is that the ANSWER trial had an 8.8% intraprocedural complication rate using the pulse writer with a 2.9% in-stent stenosis rate. Flow diversion technology revolutionized the treatment of intracranial aneurysms upon their introduction. However, they have their own specific risks related to device thrombosis or bleeding related to the antiplatelet agents needed for treatment. There is a 0 to 14% thromboembolic complication rate and a 0 to 11% rate of hemorrhagic complications. Dual antiplatelet therapy, consisting of aspirin 325 milligrams per day and clopidogrel 75 milligrams per day, is started before the procedure and is continued up to 6 months post-procedure. For a case of a ruptured aneurysm, dual antiplatelet therapy can be started either within 12 hours with a load of aspirin or Plavix or more immediately with a larger load as displayed here. Platelet function testing is an important part of the pharmacological management of endovascular aneurysms. Up to 30% of people receiving clopidogrel are either hyporesponsive or hyperresponsive to standard dosing. This is specifically very important in the use of flow diversion devices. The Verify Now assay can be used to determine if a therapeutic level of clopidogrel has been given. A goal PRU or P2Y12 reaction units is between 60 and 240 prior to treatment with flow diverting device. A level over 250 is a hypo responder at risk for thrombotic complications. For hypo responders, we recommend either increasing the dose of clopidogrel or switching to another antiplatelet drug like ticagrelor. Patients switched to ticagrelor do not require therapeutic monitoring. A PRU under 60 indicates a hyperresponder at risk for hemorrhagic complications. For these patients, the dose should be decreased and a PRU rechecked prior to the procedure. Glycoprotein 2B3A inhibitors can be very useful both prophylactically and for intraoperative treatment of thrombotic events related to endovascular treatment. The 3 commonly used pharmacologics are listed here, including epsiximab, eptifibatide, and tiroban. Eptifibatide and tiroban have a higher recanalization rate compared to epsiximab. Important to know is that epsiximab is a modified monoclonal antibody with a risk for immunological reaction, while the other 2 are small molecules without that risk. Pharmacological therapy for acutely ruptured aneurysms deserves special notice. Thromboembolism is increased due to vasospasm in the setting of aneurysmal rupture. Heparin boluses in these cases are not shown to be associated with the re-rupture during treatment. The dosing of medications are covered in prior slides for the endovascular treatment of ruptured aneurysms. Now we move on to other non-aneurysmal pathology treated endovascularly. Carotid artery stenting being a very common one. Dual antiplatelet therapy with aspirin 325 milligrams daily and clopidogrel 75 milligrams daily should be initiated at least 4 days prior to the procedure. Clopidogrel should be continued for 4 weeks post-procedure, while aspirin should be continued for life. The medical management of intracranial arteriosclerotic disease and stenosis is important. The WASID trial demonstrated aspirin is not inferior to warfarin while having a lower risk of hemorrhage in patients with this disease. The Sampras trial demonstrated the superiority of dual antiplatelet therapy and maximal medical management over intracranial stenting in patients with intracranial atherosclerotic disease or stenosis.